مثل نوره كمشكاة فيها مصباح المصباح في زجاجة الزجاجة كأنها كوكب دري يوقد من شجرة مباركة زيتونة لا شرقية ولا غربية يكاد زيتها يضيء ولو لم تمسسه نار نور على نور يهدي الله لنوره من يشاء ويضرب الله الأمثال للناس.
Doing a very low stage disease because they started to do this BT2 or less in their series and give the same results of open surgery. Most of the series dictates to do very simple way of diversion because they don't like to open the abdomen. They do all the cases like easy iliac conduit was a little bit difficult quality of life, so they deprive many patients from doing an orthotopic new bladder. This picture shows you how the bolt recurrence come from manipulation of the area of the lymph nodes and lymphatics and lymphovascular invasion, because I assume that the lymphatic cell, the malignant cells, will go through the lymphatics from the bladder wall to the lymph nodes on the side. So they cut in between, manipulate a lot in these lymphatic channels, which make a dissemination of the disease. And this has been reported recently in 2015 that higher incidence of peritoneal carcinomatosis in the follow-up of the many patients underwent robotic surgery as well as laparoscopic surgery, and this may be due to violation of the lymphatic system by these minimal invasive techniques. We have to look why the reason is that, and this is just I was invited to do some diversion after the robotic cystectomy. What we did is only have a small open surgery, incision, and then we put it inside. After we close it, the pouch has been performed through the small incision of retrievement of. They put it down again, and then they reduct the robot and fix the pouch down. So still we are in favor of doing an open surgery because of these reasons. One of the very important reasons in the open surgery is the safety, the radicality, the experience, it is rapid, adequate recoverability of the patient, confidence of surgery, the diversion technique you have a choice to do. But for the laparoscopic only minimal advantage of small incision and least pains, etc. But which is very important issue for us here in this developing country is the cost. The cost of minimal invasive surgery is to do is 30,000, and in case of open surgery it's only 8,000. So one patient by minimal invasive disease would be 3 patients of open surgery, and we're still in a very low economic level to afford that. Now the practice of open surgery, now we have to do the surgery around 4 hours. Incision is usually infraumbilical, so it is not big one. No blood transfusion now after good experience in 80% of cases, and we do very good and adequate lymphadenectomy. No limitations because there is several limitations of the minimal invasive techniques if they have regular surgery or radiotherapy or bulky disease. The recovery and need of ICU is the same, bowel habit is the same, and hospital stay even in open surgery is around 8 days. So I couldn't say there is significant advantage, at least in the meantime, in our material to shift to minimal invasive techniques with a very high cost. Can we treat the invasive bladder cancer by only resection and TUR monotherapy? The answer is not, because it should be very strict criteria, which is a clear transparent consent for the patient, very small tumor, very localized, away from the trigone, negative tumor bed at the periphery, and this criteria does not exist except in less than 5% of patients. So it is not a universal technique to treat the invasive disease. if the partial cystectomy still has a role in treatment of invasive bladder cancer, the answer is yes, but very, very limited and special indication, especially if adenocarcinoma of the urethral type away from the lumen of the bladder. No carcinoma inside is associated, good safety margin and good bladder capacity, and this also is existing only 3 to 5% of patients that we can do. But if you do a partial cystectomy, you can do it by TOR and additional therapy like chemotherapy or maybe replaced by aggressive TOR and have a minor place following neoadjuvant chemotherapy, and no available big series in favor of good survival following partial cystectomy. Radiotherapy alone, the monotherapy in bladder cancer, did not show very good results if compared to the open surgery, and few in the former time the series has been compared by selective bladder preservation. But the problem in radiotherapy in the past, the machines was a little bit primitive. Nowadays, I think, and invite the radiotherapists to have more trials of treatment of invasive bladder cancer again and again, because we are underestimating the efficiency of radiotherapy, because we rely only on old series when the tumor was bulky, the patient is unfit, and the machines was primitive. So things now are changing. So but we are as a surgeon are very arrogant sometimes. We send them all the bad cases, all the unfit patients, all the bulky disease, and then we say that they have no good outcome afterward. I think I invite them to have more trials anymore. Radiotherapy as preoperative before surgery has been tried, but also there is no significant difference if you give more radiation before surgery, but sometimes it is associated with higher complication rate in the form of some proctitis or some problem of the skin as well, and there is no significant difference in these published trials if you give the 2,000 or 4,000 rands before the surgery. Again, preoperative radiation may be revisited, as I just told you, using the new modalities of conformal irradiation, or using radiation sensitizers, or hyperfractionation, or heavy ion therapy. I think this is quite good to try again. We have more complication of radiotherapy, like intestinal complications, like surface surgery, and of course the surgery is a little bit difficult and should be grossly done after radiotherapy, because there is no anatomical planes, the tissue become more or less ischemic and 40% higher complication rate. Dr. Santa will give some post-operative radiotherapy after radical cystectomy, but in his trial, I just was wondering that the cystectomy alone had only 25% survival if compared to hyperfractionated group of post-operative radiation of 49. I don't know why radical cystectomy in all the published series are more than 55 to 60% 5 years, but in this cohort of patients, this was only. So quality of surgery is quite very, very good, and it should be standardized with more and more lymphadenectomy to achieve good results. Still, we need further hardcore evidence, prospective randomized studies of comparing these techniques together. Post-operative radiotherapy cannot be recommended. This is the recommendation for international consultation of urologic disease in 2012, and it is not recommended in patients with urothelial cancer. Further trials may be needed, and however high complication rate is expected. Chemotherapy also, I think it's not my primary job. We have a medical oncologist in our material, but we need very good, well-designed, prospective trial, appropriately powered, all together from different centers, because to me, there is no enough prospective trials to have hardcore evidence of conclusion that this line of therapy is not, because even the guidelines is telling us that we have to give 2 or 3 cycles of neoadjuvant chemotherapy before cystectomy, but only 15 to 20% of patients would follow the protocol and patients will continue treatment. It is difficult on the practical life. We have many protocols, we have many algorithms, we have many trials, but very few of these trials reach its end. Many chemotherapy can be used, and many of you now much better than me in this systemic chemotherapy, either neoadjuvant or adjuvant with marginal improvement. But nowadays, neoadjuvant chemotherapy has proved that for around 10 to 15% improvement of survival if it is adequately given to the patients with good indication. Each regimen has its own merits, cons and pro. So neoadjuvant has some side effects as well. The adjuvant also have the same, but we have to individual selecting patients on which patient is. I have to skip this issue. Still, we're trying to use some bladder sparing surgeries, but the trials which has been advocated, only the most important one of Dr. Shibley, but he was only treating the low stage disease. He gave a very good results. But after chemotherapy and radiotherapy, we have to estimate how the condition of the bladder afterward. Is it normal bladder? Is it now immune from development of new tumor? And if it contaminates the field, if I would need to do surgery later on, I think everything should be more or less compromised again. And this sounds short of randomized studies. I just like to show you that is the diversion technique. We have not to offer the patient only ileal conduit or rectal reservoir. 60% of patients would be receiving orthotopic new bladder. I have just, sorry, this is, okay, I finished. What we have learned in overuse, only 3 slides. Age of cancer patient is increasing. Squamous carcinoma is decreasing and transition is increasing by 15% every 5 years. Less bilharziosis and more smoking, but we have HCV more now involved in the pathogenesis of aggressiveness of the bladder tumor. Male to female ratio also increasing. We have high volume cases in many centers. We are doing at least in our center from 200 to 300 cases a year. Golden chance for the younger generation to learn. Many difficult and tough cases are there. 20% of patients will have pathological ureters. The base of minimal invasive surgery is narrow but slowly growing. Suitable cases for partial cystectomy is very rare. The use of total intravenous anesthesia is quite welcome for recovery. Less than 20% of patients require blood transfusion, so we can do it bloodless surgery. Adequate lymphadenectomy is quite important for improving of survival. Genital sparing or seminal sparing or whatever sparing is not a policy. Nerve sparing is welcome, but not to compromise the malignancy, and it gives 60% success rate without medication. Neoadjuvant chemotherapy is required on wider scale and is needed through powered trials. Orthotopic new bladder is a good diversion technique and should be the first choice in the majority of cases. Anti-reflux urethral implantation may be preferred in young patients. Ileal conduit and concutaneous reservoir are second alternative. No rectal diversion anymore in our practice because of the long acidosis time and some complications. Squamous carcinoma and adenocarcinoma are quite resistant to chemotherapy and radiotherapy, and radical surgery is the most important. I think this is the end of my lecture, and thank you very much.
Thank you, Professor Hassan Ibrahim, for this excellent presentation. And excuse me, I have a question regarding the poor outcome with patients having HCV negative positive disease. Do you think this negative outcome is due to the liver decompensation by the virus that would make it difficult to have proper therapy, to have more radical surgery, poor tolerance to anesthesia, and even liver decompensation may not permit further post-operative management? Would this, I think, be the reason why there is negative results in patients having HCV virus, rather than the biology of the tumor itself? It's the impact of the HCV on the patients and liver profile that would most probably not permit to give the optimal therapy to the patients.
No, what has been done is we have the two comparable group of patients as regards the fitness of surgery, the liver profile, but the only parameter was that this has the virus and this has not the virus. And still now we are now looking for explanation of your question. Why
Yeah,
this?
but do you have patients with
And both had to direct the surgery, both had recovered very well. There is no problem related to surgery.
What about post-operative?
Post-operative, they are doing the same, but we will long follow-up of
The same.
survival.
Do you mean that the virus has no affection on the liver functions at all?
No, they could recover and withstand the surgery. They had been discharged.
Yeah.
A 3 months complication rate was similar in both groups. But when we...
to surgery, but about the liver profile,
Yes.
was it the same?
What was? Yes, it was. Otherwise,
Patients with
otherwise we
compared to
cannot do it.
negative?
We cannot do surgery for the patient who has compromised function, but because we know they did worse in the recovery area, in the recovery time. So they did the same protocol of treatment, but the same surgeon, radical cystectomy, the same
What
time.
about it? Post-operative.
This is what I am looking now, the second phase of this study, why or how the HCV positive patients would negatively impair the outcome and was associated with higher stage disease and with in histopathology and was also low survival. My crude explanation.
The survivor, the patients, the low survivor, was because of dissemination or because of liver impairment?
It could be both because both are negative. The overall
But
survival and even the disease-free survival.
Yeah, I mean,
But you cannot
they die because of disease progression or of liver decompensation.
Because of disease progression, because I assume, and I have to prove this, this is now we are working for this in our lab. Why? How is the immunity of the patient? I think the immunity of the patient with bladder cancer has been exhausted by the virus. And not much immunity is still there to guard against resistance to the tumor.
Is there any data supporting this assumption?
No. This is just speculation. And now, when you have to do research...
I'm stressing on that because not only in bladder cancer, but in any malignancy, when the patients have co-incident HCV virus, it has an impact on outcome by affecting the patient's liver profile and therefore handicapping us from giving further therapy as compared to those
you
with
are right, but
negative.
the answer here is the presence of tumor suppressor genes. The virus itself did some changes on the genetic
On the
profile.
bladder,
On the bladder, yes.
data on cytogenetics of bladder cancer.
We isolated these genes from the bladder tumor and from the tumor, the normal bladder tissue around the tumor.
Yeah, but I mean, there is, to my knowledge, there is no yet data that HCV had an impact on genetic profile of cells of bladder cancer. And there is no, up to my knowledge also, so far released any research on this point. That's it. Patients with HCV virus will do worse in every malignancy, and it is related to the liver profile rather than harboring or changing the natural disease of tumors.
Maybe if we would meet next year, I would have explanation because I'm still working on this now. Now we have this preliminary observational report.
Yeah, okay.
So, and then we are now more dissecting the data, studying of more genes, inviting more chemicals, and to do that.
Okay, thank you. Any other questions? Please, go ahead.
Thank you very much. You see that extended only for 1 second for research, but many give us
Please,
there is improvement in
Yes.
survival.
The more lymph nodes you remove,
And microscopic.
yes, the more lymph node you remove, even if it's looking normal, the more survival you will have. This is because you are removing the micrometastatic involvement of these nodes. And even if you have a report in your hand from the pathologist telling you that 20 lymph nodes are negative, don't believe it 100% because 1/3 of these they have microscopic involvement but skip from the diagnosis. So we cannot make a step section every 3 millimeters for these 20 or 40 lymph nodes, otherwise we will examine the specimen in 1 week. One specimen.
Okay, thank you. Last question, please, because we are beyond schedule.
Please, as regard to bladder preservation, what about you because in a good number of trials, yes, up to now it is still not more than delaying cystectomy What about your comment? Still we are in need for more randomized trial, or this comment may be extended to the panel? Thank you.
Thank you. This is nice question. Now, the patient doesn't like to be operated. The patient has to look to keep his bladder and not to be operated unless nothing is good alternative for him. We have to do this through very prospective, controlled, strict criteria studies of low-stage disease, doing an aggressive TUR, and giving systemic neoadjuvant chemotherapy. And if there is a quite good response afterward, we can offer him the irradiation. And then I think if we do this policy of treatment, it could be successful in up to 40 to 60% of cases. The remaining patients would need cystectomy at one time of follow-up. And the question is, these bladders after being irradiated is now immune from developing a new tumor in the future. It needs the same surveillance and cystoscopy and biopsy. And what about the future of these bladders after irradiation? 15 to 20% of these bladders will be useless anymore, even if it doesn't have tumor inside because of the limited capacity, coronary cystitis, etc. So at the end, we have to treat 30 to 40% of patients with bladder-sparing techniques, and the 70% would end up by bad surgery because the time is late, the field is not fresh, so you can do only palliative surgery. But I cannot close the door 100% because we have many patients up to 50 to 70% would survive with good bladder capacity after this protocol. The medicine has no white and black all the time.
Thanks a lot, Professor Ahmad, Professor Hassan, for this very excellent interactive discussion.
And now I have the great pleasure to introduce Dr. Jose Karam, Professor of Urology at the University of Texas, MD Anderson Cancer Center, who will speak in neoadjuvant treatment in renal cell carcinoma.
Good afternoon. It's a pleasure to be here today, and thank you very much for the invitation. It's a pleasure to be in Egypt for the first time, although I'm from your neighbor, Lebanon, but I've never been to Egypt until yesterday, so it's wonderful to be here. So my talk for today is on neoadjuvant therapy in kidney cancer, and this is my disclosure, and this is the outline of the talk. So I'll start by a very brief case, and then I'll define what I mean by neoadjuvant. I'll talk about the first report, the safety, and why would we even use neoadjuvant therapy in kidney cancer. And then I'll talk briefly about the clinical trial that we did at our institution, if there's enough time for that, and then some take-home messages. So these are two patients that we treated on a clinical trial on a protocol at presentation. You see here the tumor on the left kidney, and very similar sized tumor on the left kidney, and I'll show you at the end of the talk what happened to these two patients. Just for definitions, I think any therapy that we give our patients before surgery, we can call it preoperative or pre-surgical. I think we should reserve the term neoadjuvant itself to patients who have no metastatic disease. And for those who have metastatic disease, if we give them therapy before surgery, this would be more of a pseudo-neoadjuvant therapy. But both will fall under the preoperative or the pre-surgical category. This is the first report of using sunitinib in patients with a primary tumor in place. This is from 2 centers from the Netherlands. This is a retrospective study over a 2-year period, and they looked at 17 patients who received sunitinib.
Okay, thank you very much for coming. We have a hopefully very interactive and great session in the next hour. As you've seen from the panelists sitting next to me, we've got renowned world figures in colorectal cancer, as well as regional and local renowned figures, trying to bridge what we have here and what they could offer their patients, and seeing how well we are doing or how much more we can do for our patients. And is it really?
It was about 31%. So this was encouraging to see. But we have to ask several questions in this field. Is it safe to give neoadjuvant therapy? There was one report from this group from Canada that basically, this is all in mice, this paper that I'm showing you here. They gave patients, or the mice, neoadjuvant sunitinib, and then they stopped sunitinib. And what they noted is that the tumors after stopping sunitinib grew very quickly. And basically what they said is that treating patients neoadjuvantly with the medication is dangerous because once you stop it, the tumors grow back very quickly. However, this is not the case in patients. This was a study that was published a couple of years after the first one. This is an actual patient. And what they found is that sunitinib does not really increase or accelerate the tumor growth in patients with metastatic kidney cancer. So we can give the patient sunitinib or any other drug for that matter, but we can stop it when we do surgery and we can restart it afterwards without any fear of a very rapid growth of the tumor afterwards. So I think from that standpoint, it's safe to give pre-surgical therapy. However, from a post-operative standpoint, we have to keep in mind that it's not a completely benign process. So if you give bevacizumab, you see in about 20% of the patients wound dehiscence or delayed wound healing. And this is from the prospective trial we did in our institution in 2009. But we don't see the same thing using the different TKIs. So this is more of a problem we see with bevacizumab because it's a long half-life. But when you look at sorafenib, there's no delay in wound healing. Sunitinib, it's a 13% minor wound complication rate. In our trial with axitinib, we only saw one patient, or 4% of those patients with only superficial wound complication. And in the most recent pazopanib study, there was no fascial dehiscence or wound healing impairment. This is a study that we did in our center with metastatic patients. This was a retrospective study, and we compared two groups of patients. One group that had immediate cytoreductive nephrectomy, and one group that had pre-surgical therapy and then cytoreductive nephrectomy. And one thing to keep in mind is that the patients, the majority of them actually received bevacizumab, and I think that is partially what explains the higher complication rates that we see with patients in this study treated with pre-surgical therapy. When you look at all complications, the rates were not different statistically, including the clavien 3 or more complications. But when you look at the wound complication, for sure there is a higher complication rate with wound complications and the patients treated with pre-surgical therapy. And again, the majority of these were treated with bevacizumab. The other question, after establishing that it's really safe if you use it correctly, especially with the TKIs, is why can we use it? Can we use it to make a large tumor smaller? And these are several studies, most of them are prospective. This is our study with bevacizumab. I'm going to point your attention mostly to this column here. This is the partial response and the complete response rates. With bevacizumab, we didn't see any partial responses. This is with a sorafenib study with only about 7%. With sunitinib, 28% partial response rate. This is about 5% with sunitinib, and mostly were metastatic, or mostly were locally advanced cases. This is a combined study of two phase 2 trials with sunitinib, and the partial response rate was only about 6%. This response rate with this study was about 37%, about 14% with pazopanib in this study. This was our study with axitinib, and the partial response was about 46%. But these patients were all clear cell biopsy proven. They were all non-metastatic, locally advanced tumors. And this is the more recent study with pazopanib, also very similar response rates. You can see here about 36%. And this is a combination of multiple studies using only sunitinib was about 19%. So when you look at all these studies, you can see that bevacizumab and sorafenib have a low partial response rate. And most of the responses you see with sunitinib, axitinib, or pazopanib if given pre-surgically in patients with kidney cancer. The other question is, why do we want to use neoadjuvant therapy? Is we want to try to change unresectable tumors to resectable tumors, so now we can do surgery for these tumors. And as you may be familiar, unresectable kidney cancer is not a very common occurrence, so we don't see really a lot of unresectable kidney tumors. So this was one study using sunitinib. This was a retrospective study from the Cleveland Clinic group. They included 19 patients. Most of them had metastatic disease. About half of them had clear cell kidney cancer. And they were deemed technically unresectable in 12 patients, and they had large metastatic burden in 7, and that's why they didn't have initial surgery. So these patients had sunitinib for 2 cycles, and ultimately 4 out of 19 patients were able to undergo surgery, and considered that this approach was successful. This is another study, also retrospective, 10 patients, all metastatic, all clear cell, all patients received sunitinib, and ultimately 3 out of the 10 patients were able to undergo surgery after using this pre-surgical approach. Now, the third study that I'm showing you here is a prospective study, included 30 patients, about 2/3 of them had metastatic disease, and they received a median of 3 cycles of sunitinib. And the primary endpoint of the study was being able or not to undergo surgery after preoperative sunitinib. And ultimately, about 45% of the patients met the primary endpoint of the study. And again, just to say it again, unresectable kidney cancer is really not very common. So we have to keep that in mind, and I'll talk about that at the very last slide. Now, another reason to try to use neoadjuvant therapy is to hopefully change radical nephrectomy to partial nephrectomy in patients who really need to have a partial nephrectomy, like a solitary kidney or multiple large bilateral tumors, etc. This is a prospective study that included 20 patients. Most of them had no metastatic disease, and they received about 3 months of sunitinib, so about 2 cycles. And ultimately, 8 patients were able to undergo partial nephrectomy, but they didn't really say in the study how many could have had partial nephrectomy without sunitinib at the beginning. So you have to keep that in mind when you're looking at these studies, and you'll see that in the next few slides that I'll show you as well. This is another study. It's a combination of a retrospective plus a pilot prospective study. It included 12 patients, and this is the same theme you're going to see in this talk. All these studies that I'm showing you, including ours, are a very small number of patients. And all these patients had an imperative need for partial nephrectomy. They received 2 cycles of sunitinib. And again, all patients had partial nephrectomy. But again, the authors did not say how many of these patients could have had partial nephrectomy without the need of sunitinib. This is our study with axitinib. 5 patients out of 24 had partial nephrectomy, but again, that was not the primary endpoint for our study, so we can't say how many could have had that without the use of axitinib. And we actually did a follow-up study on this that I'll discuss later if there is enough time. So this was the last one using pazopanib, and this is the prospective study that was designed to try to see how many patients can be changed from a radical nephrectomy to a partial nephrectomy. And the tumor size on average was about 7 centimeters, and using this medication, they were able to shrink the tumor on average about 1.8 centimeters. And ultimately, 6 patients were able to undergo a partial nephrectomy. So now, after discussing, changing unresectable to resectable, changing radical to partial, several studies have been published, again, all of them small, to try to downstage an IVC thrombus in hopes of making the surgery easier for both the patient and the surgeon. And this was mostly fueled by case reports. As you can see here, these case reports that I'm showing you, there's 6 of them that showed promising results. The tumor thrombus level went from a level 2 to level 1, level 4 to level 2, etc., using sorafenib or sunitinib. But these are case reports, so basically they had good outcomes, so they published it. But this is another author, Axel Bex from Netherlands. What he published is the reverse. Patients who had a low-level thrombus that got bigger on therapy, or patients who did not have a thrombus that actually developed new thrombus on therapy. So when you look at these case reports, it's very dangerous to say, well, somebody reported one patient that had benefits, so we're going to do it. So what we decided to do is we pulled our data with our colleagues from UT Southwestern Medical Center in Dallas, and we looked at 25 patients who had an IVC thrombus. And these are patients who received targeted therapy not because we wanted to shrink the thrombus, but because they had metastatic disease and they were deemed not to be good surgical candidates initially. So we wanted to give a pre-surgical approach. 19 of these patients had clear cell, about half the patients received sunitinib, and these are the IVC thrombus levels at the beginning of the therapy. And this is what we found. We found that actually 21 out of the 25 patients had a stable level of the thrombus, so did not help. Actually, 1 patient had an increase of the level of the thrombus from a level 2 to a level 3. So now we have to do a bigger surgery to clear the thrombus out. And then 3 patients had a decrease in the level of the thrombus. But out of these 3 patients, only 1 patient had a meaningful decrease, basically the decrease of the level of the thrombus that changed what we do. So our conclusion from this paper is maybe one patient out of 25 patients benefited from giving targeted therapy to decrease the IVC thrombus. And that's why our current practice is we never give targeted therapy in patients with IVC thrombus with the intention to shrink it to make surgery easier. This is a subsequent study that was done by multiple centers in France. They did a similar design, retrospective, 14 patients, all clear cell, most received sunitinib, and they found very similar findings. Most patients had stable disease. One patient had a level 3 become level 4, which now means it's in the heart, which made the surgery much more difficult, and they had to go on pump for that. And one patient had a decreased level of the thrombus, which was not really significant clinically. Subsequent studies have done the same thing. This is from Korea, from South Korea, 22 patients with a thrombus. They did the same concept. They used different criteria. They did not use surgical staging for the levels. What they did is they used RECIST, and they found that 20 patients had stable disease, again, consistent with our data. So again, we should not use these therapies for IVC thrombus. For use of metastatic patients, this is what I would call a pseudo-neoadjuvant or pre-surgical, just to keep it simple. I'll discuss that more tomorrow in my cytoreductive nephrectomy talk, but this is a study that was conducted about 7 years ago in our center. And what we did is that 50 patients were enrolled. They received bevacizumab for 2 months. And if they had a partial response or stable disease, they underwent nephrectomy. If they had progressive disease, but they had excellent performance status, they still underwent nephrectomy, but then they switched to a new drug. However, if they had progressive disease and poor performance status, these patients did not undergo surgery. And this is what we call the litmus test. And these are the results, and I'll discuss them more in detail tomorrow. We have a similar study ongoing now in our center. It's including 45 patients, but now we increase it to 60 patients. As you can see here, these are all metastatic clear cell patients, and they're randomized into 3 arms, either nivolumab alone, nivolumab plus bevacizumab, or nivolumab plus ipilimumab, and then they have their own cytoreductive nephrectomy. And we're collecting tissues, blood, urine, anything you can think of on these patients. And these are the primary objectives, to see if it's safe and tolerable, and also to look at immunological changes in these patients. This is our clinical trial that I discussed briefly earlier, and I'll go through it here in a few slides. So what we did is we biopsied everybody. All these patients had clear cell, all had locally advanced disease without metastatic disease. And they received axitinib 5 milligrams twice a day for a period of 3 months, and then they had surgery, either partial or radical nephrectomy. And our primary endpoint was simply the primary tumor reduction in these patients using RECIST. And these are the patient characteristics, just regular cohort as you'd expect, age of 60, most males, all clear cell. Most patients had radical nephrectomy. Most patients had open surgery. Surgical time was about an hour and a half, and this is the blood loss you can see here, about 200 cc's. As expected, most patients had stage T2 and higher, about 20 of the 24 patients, and 13 patients had grades 3 or 4 tumors. And using RECIST, 11 patients had partial response using just simple measurements done by the radiologist independently from the urologist reading. And this is simply here just the plots, as you can see, the sizes initially at week 7 and week 12. In red, I have the partial responses that include stable disease. And you can see a nice decrease in the size of these tumors that you can see as early as 7 weeks, but you reach a better response if you wait 12 weeks on these patients. And this is just a simple plot again to show you the stable disease versus the partial responses here. So one thing that we thought of is that we did specify in this trial if we could do partial nephrectomy without the drug. So what I ended up doing is I printed all the CDs and sent them to 5 urologic oncologists in different countries and asked them, and these are all blinded, and asked them, can you tell me if you can do a partial nephrectomy on this patient or not? So this was all blinded, they were shuffled, they didn't know if the patient received therapy or not, and they simply told me I can do it or I can't. And then of course we had different other questions. But interestingly enough, the agreement was not very good. The kappa statistic was about 0.6. And we noted that out of the 17 tumors with high complexity before treatment, only 3 became moderate complexity, so it decreased the complexity because of the treatment. And after treatment with axitinib, all 5 reviewers agreed that 5 patients only required radical surgery instead of the 8 that they thought needed radical surgery before therapy. And they also thought that 10 patients could have now partial nephrectomy instead of only 3 that were thought to to be able to have partial nephrectomy before treatment was given. And the odds of being able to do a partial nephrectomy after treatment with a targeted therapy was about 23 times higher when we give this drug. Just very briefly, we're doing, just to show you that with these prospective trials, you can collect a lot of data and you can do a lot of subsequent studies after you've published the original trial. We're looking at the pseudocapsule of these tumors to see how that will change our practice in doing a partial nephrectomy in these patients who have these tumors. Just very briefly here, just to show you that we see that the pseudocapsule is thicker after treatment with these targeted therapies, but we have to keep in mind that this pseudocapsule is not continuous. There's a lot of gas in it, so we have to be very careful not to be too close to the tumor and not to nucleate these tumors and to do a good resection margin around them. This is just to show you here the external capsule or the internal pseudocapsule here. Here you can see the tumor on either side. And this is the area without pseudocapsule where you see the tumor here infiltrating right through the kidney. This is discussing sarcopenia. Again, we wanted to look at sarcopenia to see how treatment with a targeted therapy affects different parameters, such as the visceral adipose tissue, the skeletal muscle, the subcutaneous tissues, and others. And we noted that we see significant changes when we treat the patients with these medications. And one finding that is more hypothesis generating is patients who have no sarcopenia initially tend to have a better partial response to medications. But again, this is a very small study. This is a post hoc analysis. It's at best hypothesis generating, and it's not something that's confirmed yet. Just to show you what happened to the patient number one, you can see here a very beautiful response to the tumor. This was considered a partial response by RECIST. Again, patient number two, very similar tumor size at the beginning, but the tumor basically did not change in size at all. And our problem is we don't know which patient is going to respond and which patient is not going to respond. So that's why when we did this clinical trial, we collected everything. So we have very detailed imaging, we have biopsy tissues, we have serum, plasma, mononuclear cells, and urine. And during treatment, we collected the same thing. At surgery, we collected all the kidney tissue, the lymph node tissue for banking. And after surgery, we collected the same things. And now we're trying to work to see if we can find any predictive biomarkers to tell us which patients might benefit from this type of an approach. Just to give you another real-life case, this is a patient I saw in clinic 2 weeks ago on Monday, solitary kidney congenitally, and he has a 15-centimeter tumor in the left kidney. So I talked to him about upfront surgery, which obviously we'll want to try to do a partial nephrectomy, but the patient decided, and I agreed with him, to do a neoadjuvant approach. So we biopsied this clear cell, so we're going to go ahead and give him at least 2 months and then go for a partial nephrectomy of this tumor. I'll let you know maybe in a few years how that went. So just the last take-home slides here. Is it safe? Yes, but there are some known complications. It can shrink primary tumors. It sometimes can change a radical to a partial. I hope it does that for my patient. Time's up. Okay, thumbs up for real this time. Unresectable to resectable sometimes. It can downstage thrombi, very rarely, so we do not use it ever for this approach. We should not use it routinely, so we only use it if we're stuck and we have to do something different. But I still think it can help selective patients. We still have to define what's unresectable, what's not amenable to a partial, and we still need to work to find predictors of response using the materials that we've collected. And we have to better understand still the utility of these therapies using multi-institutional trials, hopefully. This is the name of all the people who make all this work possible. And thank you very much for your attention.
Thank you very much, Dr. Jose. And now we have maybe one question.
So I take advantage of that. So in your opinion, what would be the optimum time to try the IGILUC for this neoadjuvant treatment? So you say 2 months, 3 months?
So we see the responses as early as week 6 or 7. I think 2 months is the ideal standpoint. When we look at our results, 2 months looks like it's the time when it's the best time to do it. So I wouldn't try it earlier, but if the patient is responding, you might want to try another month. I mean, that's okay, as long as you keep a very close eye on it. But 2 months seems to be the sweet spot.
I'm saying that because sometimes there are late responders. So maybe if by 2 months is still, you want to give 1 more month, I agree with you.
I mean, yeah, I would give it 1 more month,
yes.
but I wouldn't wait 6 months to find a response. I mean, if you're going to see a good responder, and I'll show some of those in my talk tomorrow,
Right.
you're going to see whoever wants to respond will respond in the first 2 months.
Right.
You'll see a signal at that time. But if there's minimal response, it's not going to happen afterwards, probably.
Okay.
So the question is, during the course of the disease, do you repeat the imaging to pick up early the non-responders and able to expose them to?
Absolutely. So what we did in our clinical trial, the endpoint was at 12 weeks. But we did not leave the patient 3 months without any imaging. So at week 7, we did imaging to see if the patients, our stopping criteria were if the patient is having progressive disease, we immediately stop the medication and they go to surgery. Now, thankfully, in the 24 patients, none of them had progressive disease. All of the tumors did shrink, so we did not have that problem. But like you said, all patients had imaging in the middle of the cycle to make sure we're not harming the patient.
The only positive sign is the shrinkage of the size or the function and the cross sign, or what is the parameters that you can tell us that this is responder and this is not responder? Only the size or something else?
So we use the size just because it's the most commonly used criteria. So we use RECIST, just simply looking at size. Now, some people have looked at what they call the Choi criteria. So what you're looking at is a 10% shrinkage rather than the 30% that you would expect with RECIST, and a 10% change in the Hounsfield units as far as attenuation on these images with enhancement. So we didn't use those. These are more commonly used in just tumors, so we didn't want to cause any controversy with the urology folks, so we used RECIST. But sometimes you see, like the patient number 2, the tumor did not shrink, but you can see on the edge of it that there is no more enhancement. But we had to call it a stable disease because that's what we decided to do at the beginning.
Excuse me, Professor Khan. Do you think there is a rationale for patients who are candidates for partial nephrectomy to go through neoadjuvant targeted therapy? And also, for patients who are operable from the start, would it be recommended to start neoadjuvant chemotherapy to down stage and they have more limited surgery? Putting the balance of that, some patients who are operable may not make benefit of targeted therapy and may have progressive disease or dissemination during this period. In other words, who are the selected patients for the neoadjuvant setting if they are operable at the start? Especially the number of patients, 24 patients, would not help us to reach a firm conclusion in this issue.
So we have to start somewhere. So all these patients that we did were on a very strict clinical protocol that has to be approved by the FDA and through an IND and all those things. So to answer your question very simply, if a patient is a candidate and can undergo partial nephrectomy, they should undergo partial nephrectomy. If the patient has 2 kidneys and has a very large tumor on 1 kidney and can undergo radical nephrectomy, they should undergo radical nephrectomy.
Yeah.
So I have to make it very clear, this neoadjuvant therapy is not something that we do in our clinic every day. So maybe I do it either on a clinical protocol and a clinical trial. That's how we learn, and the patients know that. And if we do it in clinical practice outside of the clinical trial, maybe I do it 3 times every year. As I said, unresectable kidney cancers are very unusual. So I have to make sure it's clear that not every patient that comes to my clinic gets neoadjuvant therapy before going to surgery. If surgery is doable, they get it. Now the patient I showed you at
Thank
the
you. You
end,
highlighted the very important point for everybody.
it has to be very clear.
Yeah.
But the patient who I showed you at the end, solitary
Yeah,
kidney,
sure.
15-centimeter tumor,
Yeah.
we wanted to improve our chances. That's why we're doing this. So this is very uncommon though.
Yeah, sure. Thank you.
Well, thank you very much, Professor Karam.